Good afternoon, everyone. My name is Tamara Henry, and today we'll be discussing the introduction to monitoring and evaluating programs. Thank you for being present. I'm glad that there are others who will be here to weigh in on this really important perspective in not only the grant writing process, but how to build sustainable programs and leverage the data and resources that we have when we're working amongst our various communities. So today we're going to distinguish the differences between goals and objectives, identify key tools and techniques in monitoring and evaluation, discuss evaluation strategies, and apply a logic model to an impending program that you may have. At any point in time, if you have a question, please feel free to put it in the chat or unmute yourself and just ask me the question, because we have a pretty manageable group. So I'm happy to pause and answer any questions that you may have. So thank you. So what's an intervention? An intervention is pretty much an action that we take to improve a given situation or context. And in every intervention, we should consider the socio-ecological framework, which is depicted on the right-hand side of your screen. And why this framework is important is because it allows you to conceptualize how you would like to implement your intervention. For instance, if you're working in a given community, you have options to work in group settings or individual settings, etc. So your role as the person who is leading the program management is to determine, do you want to work with your community on a one-to-one basis? Do you want to work with your community in terms of the individual and their social network? From an organizational standpoint, do you want to work with faith-based organizations, etc.? Do you want to work with the community, or are you more interested in the advocacy component of your intervention, meaning that you want to move the needle regarding legislation for a particular topic of interest using a community mobilization theoretical-based framework? When an intervention is well planned, it addresses significant public health problems. It targets a specific population. It's typically based on scientific evidence and some sort of behavioral theory. There are clearly defined and linked behavioral, educational, and/or health objectives, and it can always be measured and evaluated. One thing to keep in mind in any program that we are thinking about putting in place is to consider where this intervention will happen. The intervention needs to be relevant to the people who are involved and the places where they live, work, and play. In addition, when considering the social setting as well as the ecological context, you should consider the environmental factors as well as the behavior and attitudes that influence health, because this can very well facilitate or hinder progress as it relates to achieving your goals and objectives. So one thing that you can do initially before you get into planning your program is to do a SWOT analysis. And the SWOT analysis looks at your strengths, weaknesses, opportunities, and threats in your organization. So for instance, what are some of the positive things that you can say about your organization as it relates to the community? What are your weaknesses from an internal perspective? For instance, do you have the capability and/or the people power to move the needle on this particular intervention? What are the opportunities? So to determine your opportunities, you should look at your strengths and then think about how you can leverage those strengths for future opportunities, whether it be other grants or funding mechanisms coming down the pike. And then what are the threats? Is your organization solvent and or sustainable? Do you have a 5-year strategic plan? So just think from a very high level, top heavy scenario about immediately if there was a funding opportunity presented to you, what would be your SWOT analysis before you decide to go forward and apply? One of the ways to determine how this will essentially work is determining your goals and objectives. So we hear this term oftentimes, and we use these words interchangeably, like goals versus objectives, or goals and objectives all just being lumped into a lump sum of words. However, goals are different from objectives. Goals are aspiring and far-reaching and not limited in terms of time or other measurements. Objectives, however, should be what we consider SMART. And that acronym SMART refers to specific, measurable, attainable, realistic, and timely. So anytime we think about how we can implement our programs, each objective should tie into the goal, but be extremely measurable. You want to make it as concrete as possible. The goal is the overarching catch-all of what ultimately you want to do. You want to decrease obesity in your population. That's a goal. But how do you reach that goal of decreasing obesity is through those very concrete objectives. So there are 3 types of objectives that I want to bring your attention to. One could be an educational objective. The other could be a behavioral objective. And there's another objective that is associated with health-related objectives. Now, we will revisit these objectives when we discuss our logic model a little later, but I want you to place in your thinking cap these types of objectives and what they sound like in your organization. If your organization seeks to educate people about a particular resource, or if your organization hopes to change the behavior of a population by educating them to eat more fruits and vegetables, that is specific to behavior. Or if your organization seeks to address a health-related issue, like perhaps looking at hemoglobin A1C in terms of diabetes management, decreasing that, that would be a health-related outcome. So educational objectives seek to change specific attitudes, knowledge, or beliefs as a result of your intervention. It also increases the likelihood of people succeeding in the behavioral objectives, because in the educational component, you are providing individuals with information so that they will make better behavioral decisions. So you see, for example, in our educational objectives, it reads 75% of participants in the peer program will identify 3 barrier contraceptives by the 4th week of the program. And the reason the objective is written like that, because we need it to be specific, measurable, attainable, realistic, and timely. Now, for your behavioral objectives, we're ideally hoping that our communities and or the populations we serve will adopt a new behavior, change an existing behavior, or cease an unhealthy behavior altogether. This also increases the likelihood of achieving the health objectives. So for example, 30% of participants in the peer program will use a condom at least once the next time he or she has sexual intercourse within 3 months of the program. Again, very smart, very specific, measurable, attainable, realistic, and timely. And what we're seeking to do, again, is change the behavior. We want the people that we are serving to change their behavior. So what does that look like? And this is an example of an objective of what that could look like. Now, for a health objective, this is specifically related to the status or outcome expected to result from your intervention. This should be a big picture and of public health significance, where it specifically decreases morbidity or mortality, or reduces the incidence, meaning the new infections, or the prevalence, the overall rate, to improve one's health status. So for example, a health objective may read 30% of participants in the peer program will reduce STI, just sexually transmitted infection rates, to less than 25% after 2 years of program implementation. Note how specific this is. What you want to consider and you should think about as you're writing your objectives for any project or any program you hope to implement is that the objectives should be so clear that whoever is reading it doesn't need to ask you any questions because they got it the first time and they know what it is that you're trying to do. So now I'm going to take a break and I'm going to ask you all for a little participation just to make sure everybody's awake. So you have letters A through D, and the question for you all is which of these behavioral health objectives is correct? Now, all I need you to do is type in the chat if you believe that A is the correct behavioral objective, if you believe that B is the correct behavioral objective, if you believe that C is the correct behavioral objective, or if you think it's D that is the correct behavioral objective. So if you could just type that in the chat, I'll give you about a minute, 30 seconds. Hey, anybody else want to weigh in? Do we have, okay, thank you, thank you, thank you. Thank you. Let's see. And everybody has the right answer, and that is wonderful. So that means that you are not only paying attention, but you got it. So thank you. Thank you for your participation. I do appreciate it. So interestingly enough, a lot of people pick letter A. And while letter A does have numerical values, it is not as specific as the behavior mentioned in letter D, which reads increasing the amount of fruit consumed by program participants from 1 per week to 5 per week, which is a specific behavior with a time frame of 6 months from the intervention. So that is why this is D is the best answer. It's because it's very specific and A is not. Okay, so I have another for you to weigh in on. This will probably take a minute for you to read it over, but which of these sets of behavioral and health objectives are aligned? So is it letter A or is it letter B? So I'm going to pause, give you a moment to review, and just like you did before in the chat, let me know which one you think it is. Thank you. So which of these objectives are most closely aligned? Letter A or letter B? All right, so we have a plethora of answers. So for those who mentioned letter A, tell me your rationale behind that. Why did you think it was letter A? The answer is letter B, but why did you think it was letter A? And anybody can unmute to explain themselves. I think this is a wonderful teachable moment. So if you can just, alert me to your rationale. What are you thinking? Anyone want to explain what the thought process was behind letter A? Okay.
Well, no.
Go ahead, Leon.
Okay, I was gonna say for me, I went with B because the math, the basic math, which I'm not good at, seemed to make more sense to me. So that's why I picked B. And A was it seemed out of line based on the percentages there. But again, I support math. So, but that's what was my justification for going with B.
Thank you, Leon. Emily, what were you going to say?
I had chose A, and the reason being was thinking that if you were to increase the percentage of protected sex acts, you would be able to increase or decrease more cases of gonorrhea. So if your protected sex acts or the percentage of protected sex acts were higher, then you would be able to decrease more cases. So that was my thinking in A.
Okay, and I appreciate you explaining that, because when I give this example in class, a lot of people pick A because they look at the 50% in terms of the behavioral objective as the exact rationale you provided, that the higher the percentage is of protected sex acts, the more likely we are to see a health objective accomplished. But one of the things that's also equally important for our health objectives, and the reason that I even have this here as an example, is because a lot of the work I do is around sexually transmitted infections. And what the literature says is that from a behavioral perspective, it's almost impossible for folks, and this, you don't know the population, but these are adolescents, persons, to engage in protected sex acts by 50%. It's just the literature doesn't support that. They'll be off and on, but it's highly unlikely for them to get to 50%. So the rationale and the reason that it's B is I always tell folks to underpromise and overdeliver. So B, the increase the percentage of protected sex acts by 5% is where in our SMART objectives, the R, the realistic part, is very important, because it means that if you think about increasing the percentage of protected sex acts by 5% every year, then maybe by the end of 5 years, you can actually see the new cases of gonorrhea decrease by 20%. So it's a cumulative add-on, right? Versus having a big percentage or a large percentage happen, because that 50% is unrealistic in sexuality research. But the 5% is more realistic according to the research. And let's say 1 year that you were able to show that 7% of folks engage in protected sexual intercourse, your funder would be ecstatic that your intervention is allowing people to use condoms or whatever kind of barrier protection they have, because it means you really underpromised and over-delivered if you went from a hypothesis of 5% to 7%. So it's really about how realistic it is. And remember, the people that are reviewing your application often always are subject matter experts in this field. So they would look at the number 50%. And if they are a sexuality researcher, they say, well, that's not possible because we don't see people on average increase their percentage of protected sex. So the only thing that really is the distinguishing factor in the behavioral objective is how realistic is it. So it's super specific, et cetera, but is it realistic in the grand scheme of things? So that's the reasoning behind that. But thank you both for your participation. So what does monitoring look like? Because we hear all the time that you have to monitor and evaluate programs. And monitoring is a continuous function that uses systematic collection of data on specified indicators to advise our stakeholders, our management, and our funding sources on the progress of the intervention's objectives. Evaluation is that systematic rubric, that assessment that you use to determine on a regular basis that you are doing what you said you were going to do in your project. The aim is to not only be accountable, but determine the relevance and fulfillment of the objectives and how this may overall affect the impact and sustainability of your project. So a good way or good boxes to put this in is monitoring is ongoing. So this is something you should be doing for the entire length of your project, utilizing regular data collection and tracking your results. So some people do that monthly, some people do that quarterly. The evaluation, however, is when, let's say you do a pilot for 6 months and then your implementation is another 6 months. Your evaluation typically takes place on an annual basis, on a midterm basis. And what that evaluation is doing is saying that your intervention is working, it's not working, or what are the ways that we can improve. So monitoring is ongoing, evaluation is periodical. When you monitor and evaluate your program's activities, what you're ensuring is that you're learning from previous experience, you're improving upon your service delivery, you're planning and allocating resources, and you're demonstrating your accountability to your funders and other stakeholders. So when I go through these evaluations, I want you to think about it in terms of which objective would you use for each evaluation. So what is a program evaluation? A program evaluation often happens in what we call pilot studies. It could be a process evaluation where you seek to answer the question, did I do what I said I was going to do? How well have I done it? What could be done differently? How much have we done? So think about a process evaluation, program evaluation as your educational objective, where you are handing out flyers, making phone calls, having focus groups, recruiting people to learn about your program. So it's really just the educational component of your evaluation. And a lot of, I call it widget counting, but really being able to demonstrate to your funder that you did all the things that you said you were going to do. You had 5 stakeholder focus groups, and you had 25 key informant interviews, and you handed out 10,000 flyers on the COVID vaccine, and 15,000 people scanned your QR code. So really just how many people did you reach is what we're looking at in something like a program evaluation. Now, in the process evaluation, which is similar, we're looking at the activities that were conducted, how your coalition is working, what materials or services did your participants receive, and how the program is being implemented as planned. In your intermediate evaluation, think about your behavioral objective. And what you'll notice straight away in one of the boxes it asks, did your program change your participants' knowledge, attitude, belief, or behaviors? What happened as a result of the efforts that you provided? Can the effects be attributed to your intervention, to your program? What effects did that have? So that would be maybe a pre and post test along with your intervention to see or to determine if your population has gained anything from your intervention, but also, are they changing their behaviors as a result of your intervention? Now, a long-term evaluation goes hand in hand with your health objective. Note the questions that are being asked in the long-term evaluation. What change in injury or death occurred because of the program? Or what's the current prevalence? How many cases of blank exist now? What's the current incidence? How many new cases do you have? So think about it from the health perspective. Were we able to reduce cholesterol? It's more of the bioindicator part that takes a longer time to evaluate. So a long-term evaluation, typically greater than 3 years, whereas your earlier evaluation is more or less between the 1 and 3 year mark, where we can expect to see a behavioral change versus a health change being 3 years or more. One way to, I think, really get a handle on how you will monitor and or evaluate your programs is by creating a logic model. A logic model is a systematic and visual way to present and share your understanding of the relationships among your resources to operate your program, the activities you plan, and the changes or results you hope to achieve. Logic models are important because it helps you to define your program rationale. It articulates your program rationale. It clarifies who the stakeholders are. It also speaks to who is going to do the various jobs, the various activities that are noted in your logic model. It identifies some of the unintended effects, and it supports the rationale for planning or scaling up. So when you think about constructing a logic model, I strongly encourage folks to have the people who we often refer to as inputs, but your capacity building team, your employees who will actually lead this logic model so that you can get all of the activities completed. First things first, you want to identify the problem, the health problem or issue that your intervention will address. You want to identify the ultimate goal of the program in addressing the problem. The objectives, you want to make sure they're very clear and that they are SMART because they go hand in hand with your activity. Then you want to determine if your activity is going to be short-term, intermediate, or long-term. And that should be completely in line with the objectives as demonstrated in our earlier examples. So this is a linear model of a logic model. This logic models become very, very complex, but this is one of the nicer ways to just see it and kind of wrap your head around what are my inputs, what processes will I create to have X outputs, outcomes, and impact. So as I mentioned to you, your inputs refer to your human capabilities, your human capacity, your financial resources, the infrastructure, including the equipment. Do you have a fax machine? Do you have a computer? Do you have a printer? Do you have all your supplies? Do you have community service organizations buy-in? Do you have folks who want to be a part of this program, as well as people to provide technical assistance? The activities speak to what the program does with its inputs to fulfill the overall mission. The actions are intentional on the part of the program, so it can bring about intended change. And these examples range from providing training to education to counseling. The outputs are the direct quantifiable products of your program activities. So note in the examples that the outputs refer to number of sessions, hours of service delivered, number of participants served, as well as number of materials distributed. From short to mediate to intermediate outcomes, you should have what are the benefits for participants during or after program activities? What are the changes in behavior, knowledge, skills, status, and or level of functioning? And then in your long-term outcomes, those are the things that we're expecting to see greater than 3 years of implementation. So there are a number of assumptions at each stage of the project that could be had. And this really, oftentimes you see this with respect to who is completing the various roles in this endeavor. So this is as we start to fulfill what logic models look like. You'll notice assessments, your process evaluation, responding to the question, did I do what I said I was going to do? And your various outcomes and impacts. So this is one example here of a logic model. And you'll look, this is still pretty basic in terms of how linear it is. But the activities, you're talking about developing 2 1 hour didactic trainings. And note for your output, it's the number. It's actually the numerical value. How many trainings were held? How many one-on-one trainings were held? How many providers were trained? And then the short-term outcomes refer to the medical providers that were trained. And the intermediate is looking at whether or not children were receiving high-quality oral health assessments. And the long-term is reducing incidence of cavities overall among these kids who are 5 to 10 years old. So you'll note that in every single logic model, there is a program goal, and that's the goal that we often use to write or submit our grant applications. And there's a numerical value attached to it, 100 children between the ages of 5 and 10 over a year in a community health center. So we're looking at the short term as just the educational things that will take place, the intermediate as the behavioral things that will take place, and the long term as the health objective that will take place, referring to reducing cavities overall. And this is a more complex logic model. You'll see that not only has short-term, intermediate, and long-term outcomes, but it also has a number of assumptions that work with this. Now, this is not something that I think that you can get in one sitting, but it is a wonderful resource. They call it a logic model for a reason. It's a wonderful resource to just talk through with your team when you're determining whether or not to apply for a particular funding mechanism. And also, before you start writing, thinking about how it's going to get done. What do we want this program to look like? And starting to jot down various activities and outputs that will essentially facilitate and help you reach your educational, behavioral, or health objective overall. While nothing is perfect, there are a number of strengths as well as limitations of a logic model. So we always say a picture is worth 1,000 words. So if you can begin to flesh out how you'd like to see this executed, you'll at least know what the things are that's missing, and you can go back to your team to determine how to fill those gaps. It communicates your program to others. It categorizes organizational work so everybody knows logically what is their bowl to carry, what they can do. It outlines cause and effect linkages, so your outputs are directly related to your activities, which are directly related to your outcomes and impacts. It distinguishes what's in your program versus what's in the environment. The limitations, obviously, is it is a snapshot in time. It is a one point in time. It does not take into account any change. So if you have turnover in your organization, if COVID happens and you're no longer able to meet with people, it doesn't account for that. The logic model is literally cross-sectional and written to what we have going on in our lives as we speak, which means it may not represent your reality today. So in closing, goals and SMART objectives should be used as a framework to guide your program plans. Monitoring and evaluation are important components of both program planning and grant management. And a logic model is a useful tool to articulate program plans. This concludes today's presentation. Are there any questions that I can answer for you in our remaining 17 or 18 minutes or so? And you can feel free to unmute yourselves and ask any question you might have. I am happy to answer for you. And you can tell me about programs that you are running where you are using maybe a different evaluation mechanism or tool. Happy to hear about that also. So if you would like to share, we're open to that as well.
Hi, Tamara. Did I say your name right?
You did, thank you.
I first just want to say this is a great refresher. So I appreciate that because I get caught up, in the day-to-day, everything, trying to get all this work done and stay on top of everything. And sometimes you forget about the background on how these things come together, these programs and interventions come together. So I appreciate that. Here at our agency, Unified HIV Health and Beyond, we're located in Michigan. And we work very closely with one of our bigger funders, which is Michigan Department of Health and Human Services. So they have various tools in place to help us monitor and evaluate the programs for which we are funded to provide. One of the tools that I use heavily is called Affirm. It's a web-based program sponsored by the State Health Department, and it allows their funded agencies to enter all of their HIV and STI testing work that's being done. And there's a pretty user-friendly reporting mechanism built into that web-based system that allows me to just see how me and my team are doing and reaching the objectives that we're funded to meet. It gives me a chance to make sure that the data is correct that's being collected from our community members. It gives me a chance to see how effective we're being and identifying new individuals who are newly diagnosed for HIV. It gives us a chance to look at or to assess to some extent gaps on where we might be able to reach other community members that we might be currently missing, because we're trying to reach that, ending the epidemic goal by 2030, although I'm cautiously optimistic that the US will be able to reach it by then, but we shall see. So that's just an example of one of the tools that I use to help us stay on top of the evaluation and monitoring that our State Health Department is really big on as well.
That's awesome. So Affirm comes from the Michigan Department of Health, or is this something that you bought?
It is something, yeah, it comes from MDHHS. Yeah,
Okay.
They're the one that said, okay, funded entities, here is the web-based program. We want you to enter all of your STI and HIV testing. So we said, okay, we
Awesome.
go and enter it all in there.
Especially if it can generate reports for you.
Oh, yeah.
I think that's a wonderful resource to have. I wish more people had access to it. And if it's user-friendly, because we have a system here in DC that people don't like, that's not as user-friendly and it's not intuitive with respect to our HIV programming. So it makes it really, really difficult to get those reports and, use that data to leverage your next steps into whatever it is that you plan on doing.
Absolutely.
Absolutely. So that's great. Thank you for sharing, Leon.
Thank you.
Anyone else? Anyone else? Comments, questions, anything you'd like to share? All right, well, hearing none, thank you, Ms. Norma, for the compliment. Thank you all. Yeah, if we have no further questions, I don't want to keep you. So have a wonderful weekend and Friday Eve, and I wish the best to all of you, and I'll see you next time. Take care. Bye, everybody.
Bye. Thank you everyone for joining.